I'm a cardiologist, so I look after the patients with a lot of risk factors. So as electrophysiologists, we are interested in atrial fibrillation management. Over the last couple of decades, obesity has increased dramatically in the UK as well as in European countries, and also the worldwide. So we know obesity is an independent risk factor for atrial fibrillation in development, progressions, and also it has the adverse effect on the ablation outcome. Therefore, we are very interested in management of obesity for AF ablations. So our paper review a few important points. So the first of all, so we are very interested in looking at without compounding factors such as high blood pressure, diabetes, and sleep apnea, which can be another contributing factor to atrial fibrillation. So obesity is more like abstract risk factors. So we want to know without these risk factors, which is also known as the metabolically healthy obesity patients. So we have looked at a few studies which found to have similar effect on atrial fibrillation without associated metabolic conditions. That is the one bit we are very excited to share in this paper. The other effect are we are looking at the possible or potential changes to monitor in patients with AF and obesity. What are the underlying mechanisms of changes, namely the volumetric assessment of the ventricles and atrium, as well as the biomarkers, as well as the most important bit we are interested in the epicardial fat tissue. So which is the visceral fat, which is increased with the increased BMI. So there has been a lot of studies about association of inflammations and fibrosis with atrial fibrillation with increase in epicardial fat tissue. However, the measurements of the epicardial fat is slightly different from study to studies. So we are interested in measuring in cardiac MRI, which is the part of the measurements in our current study. At this moment, both European and American guidelines suggest to risk modify on obesity before we offer catheter ablation for atrial fibrillation. However, there is no specific guidelines or evidence on which methods of weight loss is best or on what durations for this management. It's very important for atrial fibrillation for rhythm management, especially rhythm control such as AF ablation. We need to intervene as early as possible to have the best outcome. Because the longer you wait, it can go into the more persistent atrial fibrillation, and the success rate of persistent atrial fibrillation is not as good as paroxysmal. At the same time, we do not know on what time frame we should allow the patients to try risk factor modification to lose their weight. The currently available risk factor modification programs take time, and sometimes it is very resource intensive. So there are, for example, there are a few studies done in Australia. They managed to successfully modify the patient with obesity with a physician-led model, and they have a very intensive the risk factor modifications, and it shows if you can modify the risk before the AF ablation, the outcome is better. The question is whether we can implement that type of resource-intensive management in the clinical practice is the area of interest. So therefore, we explore some other options. For example, in patients with very symptomatic atrial fibrillation, they might be difficult to do exercise, but they might be able to do the diet program. But exercise might be difficult because of the symptoms. When they do the exercise, they can start having the symptoms, and it is like catch-22 this scenario. So in this paper, we also explore the newer weight loss treatment, such as glucagon-like peptide analogs, which is very promising. So, for example, now currently available medications such as liraglutide, semaglutide, and teriparatide, these are the promising for the weight loss. It has been shown these medications can help with the weight loss as well as the cardiovascular benefits. We do not know whether these can be used in our unique population with atrial fibrillations and obesity. So therefore, we would like to explore whether these can be short-term options before we can offer them a definitive, more durable, not definitive, sorry, correct that. So more durable treatment for AF ablation, and then we can offer short-term therapy so that they can lose weight, and then we can offer the ablation to find out whether this is a feasible approach in our current study. First of all, it will become individualized approach. Not all atrial fibrillation with obesity patients are the same. Probably it might depend on the duration of obesity, and we do not know what kind of monitoring modalities such as imaging biomarker or electrophysiological changes to monitor whether there's a progress or degress with the weight loss. We know if we manage to lose weight before AF ablation, it has a better result. However, we do not know what is the underlying changes, whether this is changes in the volumetric assessment in the heart chambers, or whether this is the changes with the epicardial fat, which is also very important because it has an inflammatory component on it, and there's no fascias or partition between the myocardium and the epicardial fat. Also, we do not know which biomarker we need to follow. So this is our review paper. At the same time, we are running a feasibility study to understand the possible the mechanistic changes with our patients during the weight loss with liraglutide. So we would like to know it is the volumetric changes, or whether this is the electrophysiological changes by electroanatomic mapping, which is the EP study, which what we do as electrophysiologists, or is there any exploratory biomarkers we can use to determine which patients would best benefit from catheter ablations. We would like to offer catheter ablation for all patients if possible. However, it is a procedure. Don't get us wrong, we do it every day. It has a small risk of possible side effects, especially obesity. If we do know some patients has a higher chance of success, we would like to offer them. If we do know some patients, the success rate is not that perfect, we give them more time so that we can reverse their risk factors by providing risk factor modifications or the newer therapies such as GLP-1 therapy.